Okay, hello everybody. Thank you all for joining tonight. Tonight is one of our final webinars. We have one more webinar after this one, and we complete the course in our ECMO and MCS course by Saving Lives Academy. My name is Ahmed Hijazi. I am an intensivist and an anesthesiologist working at London Health Sciences Centre, and I'm an associate professor at the University of Western Ontario, and I will be your moderator for tonight. I want to thank our speaker today. We have a distinguished speaker from Kuwait, Dr. Abdurrahman Al-Faris. Dr. Abdurrahman Al-Faris is currently the chair of the Department of Anesthesia and Critical Care Medicine and Pain Medicine, and the director of the Kuwait Extracorporeal Life Support Program. And he works at Amiri Hospital and the Ministry of Health in Kuwait. He's also the program director of Adult Critical Care Medicine, the fellowship program in Kuwait at the Kuwait Institute of Medical Specialization. Dr. Al-Faris graduated from the UK at the University of Birmingham, and then he did an internal medicine. He did his medicine training in critical care, initially obtaining an MRCP in the UK, followed by residency in internal medicine at McGill University in Canada. And then he did critical care training in Toronto. He obtained his American Board of Internal Medicine certification and his FRCPC in internal medicine and critical care in 2016 and 2017, respectively. And then he pursued further training in extracorporeal life support and critical care echo at the University of Toronto. After he obtained the National Board of Echo certification. I want to welcome Dr. Al-Faris. He will be talking to us about LV unloading on VA ECMO, a very hot topic, a topic that we received a lot of questions on. Since day one of this course, people have been asking about unloading on VA ECMO. So hopefully today he will help us answer some of the questions that you've had throughout the past few weeks. And he'll be talking to us about why, who, how, and when we unload patients on VA ECMO. Thank you very much for joining us today, Dr. Faris. The floor is yours.
Thank you very much, Dr. Hijazi, and for the Saving Life Academy for this kind invitation. I have no conflict of interest to declare for this presentation. I'll take you through a simplified case, some rationale for LV unloading in VA ECMO, indications, optimal strategies, ideal timing, and then how do we manage concomitant multiple devices. So this is a 38-year-old lady who's admitted to the hospital with viral pericarditis. She rapidly progresses to fulminant myopercarditis and supported with VA ECMO. You put a multi-stage drainage cannula, a 23 French, in the right femoral vein, a return cannula in the left femoral artery, and a reperfusion cannula. You put the patient on 4 liters per minute of flow. The FDO2 is 100% and the sweep gas is 2. And she makes some stability, or she becomes slightly stable. This is her echo initially on support with ECLS. The following few days after stability, you notice that she's requiring more inotropic and hemodynamic support and more ventilatory support. You notice that she loses pulse pressure, and this is her blood pressure, with maximal support that you could provide. This is the echo that you see, and I'm going to repeat it again, the images. So the first echo is quite full of smoke, and the other one shows that the aortic valve that was opening and closing does not open or close anymore. So in this situation, what would you do? So do you increase inotropy? Do you decrease ECMO flow, increase ECMO flow, or insert a left atrial drainage cannula? Almost there. Nearly 50% answered. Just a few more. Okay. And we have 50% of you answering D. is the correct answer. I don't know whether you heard the claps there or not, but this is what happened. You insert a drainage cannula and the aortic valve starting to open and close again, and you decompress this LV. So why this problem happens during VA ECMO? So just a quick background. I'm not going to reiterate why VA ECMO is used, but it's usually used as a bridge to recovery, hopefully in the majority of patients. But some people need support with heart transplantation or a durable device, or a decision for if the support is unfortunately futile. Throughout the years, this is a bit of an old slide from 2017, but the data hasn't changed much. You see a huge adoption or a wide adoption of adult cardiac support over time. But unfortunately, over the past 2 decades or so, the mortality hasn't changed much, ranging between 40 to 50%. And it's because managing patients on VA ECMO is quite intricate. You have to balance preload, afterload, inotropic support or not, mechanical ventilation, any additional mechanical circuitry support that they will be on, fluid balance. So it's not, and all the complications that you might face as well. So this is not an easy task that you can manage and support these patients throughout their either recovery or a destination therapy. And while ECMO provides a significant hemodynamic support and improves perfusion to the vital organs that we're supporting, the drawback is that there is a constant flow throughout the circulation against a LV that is diseased and leading to distension. And this we see it more profoundly in peripheral VA ECMO rather than central VA ECMO, which are the major two modalities that we're going to talk about here. So in central VA ECMO, you have your outflow ascending aorta cannula placed where you bypass the LV completely. With peripheral ECMO, you inject whatever amount of flow that you inject back, and all of that is pushing against an LV that is trying to you're trying to support and make it improve or recover with time. So we go to our next question. During peripheral VA ECMO, continuous retrograde infusion of blood into the descending aorta results in all of the following except. Just a few more seconds. Absolutely correct. So this continuous will never, retrograde flow will never improve the problem. So what happens in those patients? This continuous retrograde infusion of blood into the descending aorta leads to progressive LV distension and status, exacerbate myocardial ischemia. It can cause arrhythmia, pulmonary edema, thromboembolism, and compromises timely myocardial recovery. And if you are, I'm not going to dwell too much on the PV loops, but if you see what happens in normal physiology and what happens with systolic heart failure here, where you have a diminished, significantly diminished stroke volume, VA ECMO, although it improves the pressure over time, but you get very significant LV distension that might happen with those patients. So what do we see? The afterload goes up, the aortic valve closes, and the native cardiac output drops. The LVEDP or the LVEDV significantly rises, and this causes the LV to distend and thrombus formation happens. The wedge pressure goes up, the LA distends. That results in the pulmonary artery pressure going up as well, leading to pulmonary edema and maybe hemorrhage. And eventually the CVP go up and the right heart completely distends and fail. So who is the next question that we're trying to address? When you look the literature, quite not very informative or specific here. 30 to 70% are reported to have developed increase afterload during VAE CLS, but only 10 or even less than that number, 10 to 20% require invasive interventions to decompress the LV. It's associated with improved mortality, and we're going to go about some literature there. And LV unloading has been associated also with higher rates of recovery or bridge to advanced therapies, more successful weaning, and lower in-hospital mortality. And we're going to dissect all this data. You really have to balance the risks and benefit of placing additional MCS devices. And because your primary goal here is to facilitate LV recovery, you want to unload or use unload devices that associate with significant, what you're going to use are be associated with significant complications like bleeding, vascular access, hemolysis, coagulopathy, etc., in a very vulnerable population where all these problems coexist. And you also have to factor how much complexity all these devices added to the patient care and whether they could be mobilized, positioned, and to aid their recovery and improvement. So we come to our third question. The following are indications to unload the left ventricle, except. So LV stasis and thrombus formation, VTI, LVOT VTI more than 12, lack of arterial pulsatility, or absence of aortic valve opening. And just a reminder here, what's the exception that LV unloading is not indicated in? Great. Amazing audience. So the majority have chosen that the LVOT VTI more than 12 might not be an indication at all for inserting an unloading device. Just trying to go to the next slide. So if we look at indications, you can split them into hemodynamic, echocardiographic, or clinical indication. It's been reported that a wedge pressure as a surrogate for LVEDP, if it's high, if it's elevated, then that might be an indication for inserting an LV venting or starting your unloading strategies. Lack of pulsatility indicates that the aortic valve is not opening or closing, or the function is exceptionally diminished. And here might be another reason why you want to unload the left ventricle. Echocardiographically, if the dimension of the LV is significantly enlarged, if you notice stasis or smoke or initiation or formation of a thrombus in the LV, absence of the aortic valve opening, and a left ventricular artifact tract velocity or LVOT VTI less than 10 centimeter, where there is a severe myocardial injury that is happening, leading to reduced cardiac output. And clinically, having arrhythmias or pulmonary edema might be an indication that your LV is causing more harm, the distension there, than what you would wish for those patients who are supported. And when you look at the literature there, devices similar to the Impella that we're going to talk about shortly, significantly, when in addition to ECMO, reduces pulmonary capillary wedge pressure. When you look at the data that looks at what echo findings of patients on VA ECMO, significant smoke or spontaneous echo contrast and thrombus formation happens even earlier on, even on day 0 or 1 from patients supported on ECMO. Moreover, Alan Combs and colleagues in France demonstrated that using the intra-aortic balloon pump with VA ECMO simultaneously decreases the hydrostatic pulmonary edema and significantly in comparison to ECMO alone. We've conducted this is unpublished data, hopefully we have it published soon, but we conducted an international survey of ELSO centers, around 700 or so. We had 340 responders. 240 of them practice or uses VA ECMO in their regular practice. And this is a survey of program directors. the majority of them utilizes echo as a parameter in deciding whether LV strategy or venting strategies will be applied or not. And it's especially going down from echo, the most predominant, clinical and hemodynamic, which is very obvious. And then some centers use it prophylactically. And we're going to discover from the literature why or how they do that. Biochemical parameters are not very used. And a small proportions of centers have a time frame where they would initiate venting strategies. Robert Trulloso and colleagues in a review recently published what could be used as a stepwise intervention where they looked at different arterial line pulsatility, central line and venous saturations and CVP, echocardiographic parameters, Swan-Ganz, chest x-rays, and they would go from mild, moderate, and severe reduction or worsening grading, and that would move them from non-invasive support to more invasive techniques with increasing severity of presentation. So how can we do that? We come to our fourth question, is the following procedures lead to effective LV unloading, except. So is percutaneous left ventricular SS device, pigtail cannula in the left ventricle, addition of a venous, it's supposed to say a return cannula, apologies there, and atrial septostomy. Okay, great. Addition of a venous return cannula is the that wouldn't really vent the LV for us. So there are numerous strategies that you could use and utilize to unload your left ventricle, and you should always start with a non-invasive approach. The initial management that you would do is try to manipulate your ECMO flow and see whether that would reduce any issues. We couldn't have done that in the case that I presented earlier because you've already are on maximal flows and you're requiring so much inotropic and vasopressor support, and the valve would not open and close and you can see smoke happening. So reducing the ECMO flow in the case that I presented earlier wouldn't be that much helpful. But in the majority of patients where you face issues where you suspect that the LV is significantly loaded, then reducing your ECMO flow or manipulating it would be the primary thing that I would do. Using vasodilators or inotropic support, depending on whether you want to force the aortic valve to open and increase the contractility, or you want to decrease the preload, would be things that you might want to entertain to see whether you could improve the situation of the patient themselves. And then always the dilemma that we have in the intensive care unit in these patients, whether we need to diurese them or where they're volume dependent, especially if there is a right ventricular failure, and decision whether they're diuretic responsive or you need support further. So these things you have to think about or optimize before you jump to more invasive strategies. Invasive strategies, we're going to discuss those that I have outlined here in a little bit more detail. So I have mentioned the non-invasive and the pharmacological strategies here. When we go specifically on invasive procedures, the literature is enormous here. Unfortunately, it's majority of the time they are observational and opinion papers regarding interventions here, but there are plenty of them in the literature and if you want to explore them. We're going to talk about the most predominantly used tool, which is the intra-aortic balloon pump. And deflation in systole, it decreases afterload during LV ejection and promote forward flow. And there is, during inflation and diastole, improvement in coronary blood flow. It's also claimed that it improves cerebral blood flow in those with a pulse pressure more than 10 millimeter mercury during utility with VA ECMO. Impella device that is exponentially increasing in utility globally. And when it's combined with ECLS, despite, regardless of the type, whether it's the old 2.5, CP, 5, 5.5, etc., is, what is sought is very similar here. Globally, the name that is used as a combination is either a Camella or a Capella, whether you're in Europe or North America. And here you seek to reduce myocardial wall stretch and improve coronary blood flow. And as I demonstrated earlier in Derek Witterman paper, that there was a significant reduction of pulmonary capillary wedge pressure and improvement in pulmonary flow and a reduction in right ventricular afterload when these devices are used. Another technique that you can utilize is either atrial septostomy, where you just do a puncture and create an ASD, and that will draw blood from the LA to the RA and offload it that way. Or you could put a cannula that goes straight to the LA through that septostomy and drain just the LA, where you have a cannula that only the tip of the cannula can drain. Or you can do what is known in the literature as LAVA, which is left atrial VA ECMO, where you have a cannula that is multi-stage that can drain both the LA and the RA and decompress both of them. So these are the available techniques that you can unload depending on preference, institutional preference, and comfort of the care team as well. Other modalities that you can decompress, whether LV or RV, is what LivaNova produce, tandem heart. That is very similar to what I've described earlier, where you put an LA cannula, but here you could do it with an oxygenator or without. And the cannula that's unfortunately not available in our region, Protect Duo, but there are something similar that can drain from the RA and inject it to pass the pulmonary valve. If you're interested in this topic, I would draw your attention to Derek Donker's simulation paper published in SIO Journal in 2019, where they try to simulate cardiogenic shock. The video is quite lengthy here, but this is where you see both LA, RA, and LV and RV pressure and what happens to them, what happens to the PV loops in those chambers, and how significantly the stroke volumes are affected. And the next clip is where you see these loops and when ECMO is initiated and how it leads to significant LV afterload. And then they insert each venting technique and you see what happens to these PV loops. And this is the summary of that simulation study, where ASD or septostomies, if you're creating them, you would see that there's significant improvement and reduction depending on the size of the hole is created. And when you see different techniques that we've talked about, whether the balloon pump that has marginal affection of true reduction of pressure versus LV venting either with an impella or an LV direct vent to the ventricle itself with a pigtail cannula, or using the impella 5.5 here, or even 5.5 have not been simulated there. It wasn't available, but I would anticipate that the reduction is even more significant and the improvement. But when you look at the most recent two major randomized clinical trials of VA ECLS in cardiogenic shock, you see the utility of an additional mechanical circulatory support quite small. So in ECMO CS publication in 2003, where it showed a similarity between conservative and ECMO support for cardiogenic shock, only 17% of patients had another mechanical circulatory support as a venting strategy. So that might be an issue why those on ECMO did not do very well. And even in the most recent larger trial, ECLS shock, again, unfortunately negative, but the utility of LV venting was significantly low. Only 5.8% of patients who were in the ECMO arm received it. And in the other arm, just a small proportion who were transitioned to ECMO, another or an active venting unloading. So a small proportion of those who crossed over required it as well. So we go back to the survey that we've conducted of ELSO centers, and we see that the majority of centers utilizes either the Impella or the intra-aortic balloon pump, with a smaller proportion that using atrial septostomy plus or minus LA cannula, less with tandem heart and direct LV apex. But there is a proportion where you might never use venting strategy, and this is probably the majority of patients. So when we look at global data, this is an ELSO registry of adults receiving peripheral VA ECMO from over 10 years. And you can see significant increase in the utility of VA ECMO over time, with steady use of, in black here, you might not see it in the background, of intra-aortic balloon pump use. But in the most recent years, an exponential rise for the use of Impella and peripheral VA VAD devices. Outcomes and whether it's a useful strategy or not. So we've conducted back in the day in Toronto, back in 2019, we published this systematic review of all what we could find at the time. And it's almost all observational trials. And we've divided them into venting only papers and whether a paper that published something about venting and non-vent. Around nearly 7,000 patients out of 64 studies. And we found that the highest utility venting modality was the intra-aortic balloon pump, followed by Impella or a surgical vent. And some patients had mixed strategies. Another question that we wanted to address was the time to vent, and I'm going to come to that later. The time to vent was quite short. And we've identified that weaning and short-term or in-hospital and 30-day outcomes were significantly better when a venting strategy was done. Here you see the short-term 30-day survival is significantly improved, and where you see here the forest plot going towards favoring VA ACLS with an LV vent. And we divided them by balloon pump, Impella, surgical vents, or mixed. But I have to say that the majority of these papers that we've reviewed were quite significantly, moderately, or high risk of bias. They're all observational, so you have to take this data with a grain of salt. But whatever is available out there showed in 2019 that putting an ECMO, an LV vent when you need it improves short-term outcome. And I'm going to say a little bit more later. When you go to other studies, here's a comparison by Sarah Tapper and colleagues from the States, where they compare their practice or their experience with Impella, different types, or the surgical vents, and they wanted to see which one is better retrospectively, and they could not identify one modality is superior to the other. When we look at more recently, in the past couple of years, these were not included in our systematic review. Derek Westerman and colleagues looked at data from 510 registry patients in Europe, a utility of Ecamella versus ECMO alone, and they could demonstrate that in a matched cohort that there might be a trend, although it's nearly a confidence interval of 1, but nonetheless it's significant improvement when Ecamella is used. But from a Japanese nationwide administrator data by Takashi Nishi and colleagues, they looked at VA ECMO plus a balloon pump versus VA ECMO alone. Even after propensity matching, there was a significant survival benefit to the combination of therapies. Again, this is all observational, non-randomized data. So we see that the utility in the States over these 2 years have significantly increased of 2 mechanical circulatory supports. But we look forward to this trial from the UK, Hercules, where they are looking at the hemodynamic effect of reducing left ventricular afterload with Impella versus balloon pump with a specific time frame and see which modality is superior to the other. So trying to wrap up things here, when we've looked at unloading criterias and your decision making, but all the studies that I've presented so far have, or the majority of them, especially from Southeast Asia or Europe, they have a kind of a prophylactic approach to using Impella or the balloon pump. They might even use it prior to putting VA ECMO on or putting them simultaneously at the same time. So when we try to explore the time frame, whether early venting or late venting, we really try to dissect these papers. They were very difficult to get this information from because it was not forthcoming. But we try to split into having a vent within 12 hours, either at the time of ECMO or within 12 hours or beyond 12 hours if the paper was clear. And here we could highlight that if the vent was inserted within the first 12 hours, we see benefit. This is the first part of the forest plot. But when we look at studies that had it inserted later, although there are very few, we don't see that effect reproduced. The same thing with successful weaning. In all patients, venting was helpful. In the early venters, it's even more helpful, but in the late venters, we don't see the effect is reproduced. And this question was very, popular during that time where, again, Derek Westerman, the paper that I presented, look at early and late. And here they had even shorter period of time, 2 hours or more than 2 hours, less or more. And they could demonstrate that if it's done within less than 2 hours, so either at the same time or less than 2 hours, you would see the difference. Here, the hazard ratio is 0.79 with p-value of 0.03. But when you cross the 2 hours, the hazard ratio is the same, but it's not statistically significant. Similarly, Minchul Kim and colleagues conducted this randomized control trial of early unloading versus late of around 116 patients or so, where they could not demonstrate a benefit for early versus conventional, but 50% of the patient in the conventional arm crossed over to having a vent, and here it was with a septostomy. And you see in the second Kaplan-Meier curve, where if you split it that way, you would see a significant difference between the two groups. Unfortunately, we were looking forward toward the results of the reverse trial and randomized trial of Impella CP with VA ECMO versus none, but this was terminated due to lack of recruitment. Complications, very briefly. This is the last question, I believe, of the day. The most common complication of unloading devices combined with VA ACLS is renal replacement therapy, nosocomial infection, stroke, or hemolysis. Almost there. Can you see the results? Amazing. Hemolysis. Hemolysis is the correct answer. So we go back to our systematic review. This is when we pulled all the data together, hemolysis was the significantly or the most significant complication that we've seen with these different studies predominantly. And similarly, in the ELSO data, pool data that I've presented earlier, you can see that mechanical unloading in totality there isn't a significant difference here, but the hemolysis was significantly swayed towards the venting or unloading techniques. Weaning, just briefly, with colleagues from the Cleveland Clinic, we wrote this opinion paper about how should we effectively wean these patients. So I'm not going to talk about weaning in general, but how do you wean? Which device do you wean first? So we proposed this schema where you look at the reason why did you utilize cardiopulmonary support, and then you might want to favor removing the device with the most complications and ability to last longer. Specifically here, I want to talk about the combination of Ecamella and Acapella. It's a quite critical aspect of management is balancing the rate of the flow that you can provide, since it can give significant, depending on the device of Impella used, can give you a significant support or cardiac output. So you have to balance between achieving adequate systemic perfusion and how much unloading you want to do. You also have this balance has to be very dynamic. Initially, you might need a significant more via ECMO support, but later on, you might transition more towards the peripheral VAD support that can transition to patient to more mobility and less complications. But you have to pay attention to the lungs throughout these days. If you have somebody who's significantly hypoxemic, whether it's a pulmonary edema significant or ARDS, then if you utilize very high VAD or Impella support, you might lead to what is known as north-south syndrome or Harlequin syndrome, where you're going to distribute deoxygenated blood to the brain and to the peripheral circulation in the top part of the body. So sufficient preload is crucial as well, so that you can prevent suction events and reduce hemolysis, and the conundrum of biventricular failure and which support you would favor initially. Protocols. In our review paper, we talk about different protocols of weaning LV Impella devices. And here you have different ways of doing it, whether it's a stepwise reduction by 2 P levels every 2 hours, gradual reduction every 12 hours, or reducing support from a full to 1/2 to the lowest level pre-explant. And this is basically institutional preference. How would you do it? Or you could follow what the manufacturer recommends, a rapid or a slow wean. That's the preference of choice and the comfort of the team. Things that might utilize, there is some published data about utility of end-tidal CO2 that correlates very well with pulmonary arterial VTI. And here you would, with the reduction or with the significant rise in support from Impella, you can see a significant reduction of the end-tidal CO2. I'm not going to talk about Impella 5.5. It's quite similar, but can give much more significant support than others. So how can we decide? You can use this schema by Azad and colleagues that was published in Circulation, where you decide with ECMO support, escalating it, and when you face some clinical and echocardiographic complications, you can use your loading strategy. You can use a time frame. Here, Saeed and colleagues in lung, they've decided or use it time criteria. Or you can use more detailed LaRusso approach, where you have almost every single step that you have an explanation or what you would do and which device you would use to unload. So in conclusion, ECLS utility is increasing globally, but without major changes in morbidity and mortality, unfortunately. Increased left ventricular afterload, if untreated, has some detrimental effects. And numerous tools are available to unload, each with its own advantages and disadvantages, and you have to be familiar with and your institutional comfort with and your team. Weaning from these devices should prioritize adequate perfusion in the face of reduced complications. And just the last slide of the day is where the future might lie. More physiological ECMO. John Fraser leading this field from Australia, where they propose a pulsatile VA ECMO that can mimic physiological support. And here you don't have that much LV afterload. Your brain is functioning better. You don't have issues with microcirculation, inflammation, renal function, etc. So this might be the future. We'll wait and see. Thank you very much.
Outstanding. Thank you so much. Really beautiful presentation. Sums it all up and brings it all in context. I have a few questions from the audience, and I have a question of my own.
Of course.
I'll start with my question, a bit selfish of me. So if you, like in your practice, you just have a patient similar to the one you presenting with cardiogenic shock secondary to, say, viral myocarditis, would you preempt or would you wait and see for the unloading? You're putting her on VA ECMO, would you do the same as you presented, just put the balloon pump or Impella right at the start? Or would you wait?
Yeah. So my current practice, I would say my current practice, or even during my training back in the day in Toronto, we were not doing things preemptively. So we don't both devices together unless, currently the majority of the utility that we're doing is with post-cardiotomy shock, where there is a comfort from the teams in cardiology and cardiac surgery is to have the balloon pump at the same time when the patients come to us. So in that specific population, these two modalities are used together when the patients come to us. But I tend to be more reactive than being preemptive. But again, when I embarked on looking at this topic and researching it back in Toronto, I thought that we were underutilizing LV venting. Over there, the most predominant strategy was an LA cannula because physiologically it made sense and it's the best unloading that you might do, even from simulation studies. But it's quite cumbersome and requires a lot of intervention. And, it's not something that you could do at the bedside. You need to go to the cath lab and all of that. But as I said, in my current practice, I'm not seeing that much LV afterload that we have to do so much interventions for.
Perfect. That's exactly the same practice that I've seen in London, Ontario, where I work part-time right now, and I work in Saudi as well. But that's exactly the same practice that I see. It's mostly reactive for non-cardiotomy shock patients, and then the cardiotomy shock patients, I find that the surgeons are a little bit more, a little more preemptive with their LV unloading strategies. Excellent. So the question from the audience here, who usually does the atrial septostomy? So that is done in the cath lab by interventional cardiologists, unless you have other.
Yeah,
Yeah.
no, it's by interventional cardiologist, yes.
And what are the complications? And does the name of the configuration change after you put in a septostomy?
So I guess, the name, as I mentioned, depending what cannula you're using. So if you're using an LA, a small French LA cannula that has only the tip drainage, so you're just draining the LA itself. But as I mentioned, the lava, what is reported in the literature, where you have a multi-stage that could drain the LA and the RA. So in those patients, that the terminology uses lava. But again, these are all, nomenclature that, the community is gone very, beyond this terminology and maybe more specific with more detailed lettering and things like this. So the names doesn't matter. What are the complications?
What are
The
the
complications with the aftermath that you have to think about and worry. You're going to create an ASD, you're going to create a hole. So if the patient recovers, and is not a bridge to a device or to transplant, then that might be an issue later on. So, and even if you're putting a device, if you're putting a VAD, a permanent VAD, then that hole has to be closed. Otherwise, you'll have a continuous flow that's not in the patient's best interest.
Yeah, perfect. Absolutely.
Um,
LV pigtail, they're asking what is meant by an
yeah,
LV.
this is not something that I've seen in practice, to be honest, but this is reported in Europe, a lot in Italy, where it's a surgical pigtail. Either a surgeon inserts it directly to the LA, or it's a pigtail that is inserted to the apex of the LA. So there are two, either interventional technique or a surgical technique. But to be honest, it's not something that I've seen done practically. It's reported in the literature.
Perfect. Does the atrial septostomy provide immediate improvement?
Yeah, as I demonstrated, it depends on the size, or as demonstrated actually by these simulation studies. So the larger the hole that you're going to create, the more unloading that happens. But sometimes the septostomy per se alone is not enough. So you're going to load the whole area as well there. And there where cannulas that drains a liter or a liter and a half from the LA would be helpful.
Perfect. Is weaning, when you're weaning, is it mandatory to wean the drugs before the device?
Not necessarily. There's no specific guidance here or evidence-based weaning techniques. So it's to the comfort of the team and what the institution will use. But of course, I won't wean patients of ECMO if they are on a humongous amount of pressors. This is not something that I would recommend or do. And I wouldn't put epi nor epi point 2.2 just to remove ECMO. Okay. Actually, in currently my practice, at least for the past year or so, past couple of years, we've utilized more retrograde flow, PCRTOs, and we've found that you just switch the circuit around, that you allow the circulation to go in the kind of the normal fashion. So you, instead of you're pumping against the femoral artery, you will drain from the femoral artery and go back to the venous system. And here, although it has certain caveats that you have to pay attention to with the reperfusion cannulas and things like this, but we've seen that we could pick up patients who won't be able to separate from ECMO better than our regular techniques, where we drop the flow to one or whatever lowest flow that you want and do our echo imaging. You would clinically see with hemodynamics or lactate, venous saturation, etc., see who are actually able to separate. But I don't think it's mandatory to wean a drug before you remove a device.
Perfect. And
Be careful with-
yeah, when with your practice, when you do that, when you reverse the flows in part of the weaning
Yeah.
attempt, how long do you keep them with reversed flows?
So we've been doing it for a couple of hours, up to 4 hours or so. We worry about the reperfusion cannula, whether it clots, and we have issues there where we cannot unclog it, since whatever flow is achieved in the circuit is less than a liter or so. But we've detected patients who are not weanable, and where the RV is the major problem, because we don't think a lot about the RV, unfortunately, although I think it's the chamber that is the most important, where the suction that you're doing with ECMO of 3-4 liters, even a liter or two, is significantly decompressing or reducing your preload. So if you allow that extra volume to go through the circuit, we've discovered patients who might LV look perfect by echo. VTI is great, the ejection fraction is better, the function is better in the LV, but the patient could not withstand decannulation.
Yeah, perfect. And yeah, to answer one of the questions here, do we change the cannula sites when we reverse the flow? No, we don't. That is correct, Abdurrahman. Yeah. We don't change
Yes.
cannula sites. It's just the same cannulas. We
No, no,
just,
we don't. The same cannula, it's the same circuit,
yeah,
but we effectively remove the pump. So you
right.
don't pump against, you just allow the circuit to go in the normal flow. So you're depending on your native cardiac output solely.
Perfect. Can we wean off the balloon pump? I think this is the last question and we'll close off. Can we wean off the balloon pump first before VA ECMO decannulation? That was a question.
Of course, you can wean whichever, as we described in the opinion paper that we had, but you always think about weaning the device with the more complication or most complications first. So if you fear that the ECMO itself would cause more hemolysis, for example, or your circuit is clotting, or whatever complication that you might face, I would remove ECMO first. You can remove both of them together if you want, but again, I go back to the practice that I've been seeing currently with my colleagues in cardiac surgery. They would prefer to keep the balloon pump for a day or so after, just to reassure the whole team that things are fine. And we never faced a problem once we've decannulated ECMO first and then balloon pump on the second day. Patients have been cruising fine.
100%. Yeah, I
Those
would
are
agree. Well, if they are having complications from one device, then definitely that device needs to come out first. But I would agree with that practice because it makes physiologic sense that, VA ECMO increases your afterload. It hinders your chances of your myocardium recovering, whereas a balloon pump actually reduces your afterload and improves the chances. So I would wean VA ECMO first and then keep the balloon pump to improve my chances of myocardium getting better, and then maybe balloon pump a
absolutely.
day or two later. I think that would be my rationale. Excellent. I very much appreciate your presentation. It was very enlightening. And I think, we saved the best for last. So much, much appreciated.
Thank
And
you so much. Thank you so much for this invitation.
oh, thank you. And thank you, everybody, for joining us tonight. And we appreciate that everybody that has joined this webinar from the start has not left. Like you can see, the numbers are consistent throughout, which tells you how good the presentation was. People were not. So thank you again. And we hope we see you again in future webinars and seminars, and all the best to you and your team. Thank you.
Hopefully see you in Kuwait soon.
Inshallah, soon. Okay.
Thank you. Thanks a lot. Bye-bye.